Good morning, guys, and welcome back. Today we're going to be beginning the respiratory system. So we're going to go over some very important basic concepts before we go into the slides. So we have alluded to the respiratory system when we were discussing the circulatory system. We said that this is a system that transfers a lot of gas fluid, and we mentioned that fluids are not just liquid. So blood is an example of fluid, but that's an example of a liquid fluid. So remember we discussed that we have fluids. There's two kinds of fluids. There's gas fluids and there's liquid fluids. And we discussed that when it comes to liquid fluid, we needed a pump. So the heart was a pump that generates a pressure gradient. Very good. This pressure gradient is going to propel the blood fluid. Now we have the blood fluid being pumped, and it propels the blood fluid through a blood vessels. These are the blood conduits. These are blood vessels, conduits, and tubes that allow for the blood to be pumped through them. This is the medium for the transport of this blood fluid. Now, is fluid only limited to liquid fluids? Obviously not. So in addition to liquid fluid, we have gas fluid. And we've already mentioned that there are biophysics that must be obeyed in order for fluids to move. We need a pressure gradient. That's why we had a heart. We had a pump to create a pressure gradient to propel blood through the blood vessels. Then we've also learned that gas is another type of fluid, like air. So the air we breathe is an example of a gas fluid. The same way the blood is moving from an area of a high pressure, to an area of a low pressure, so should the gas also. But when it comes to the respiratory system, we have the lung. That's the major organ of your respiratory system, the organ system. The lung is not like the heart. The lung does not pump gas fluid. The lung does not pump air. The lung is a medium itself. The lung is an intermediate, is in the middle between two compartments. Between the first compartment, what is the first compartment, number one? The first compartment, number one, that is the atmosphere, ATM, or the atmosphere. So the atmosphere is the first environment. And the second environment is your blood circulation. Is your blood circulation. Is your blood circulation. And the last compartment is the tissue. Is the tissue compartment. Is the tissue compartment. Tissue compartment. Those are 1, 2, 3 compartments. Don't forget what happens. So what's the order now? The order is air flows into the lungs. That's the first step. That's step A. Air flows into the lung. Then the lung is going to exchange air with the blood vessels. Then the blood vessels are going to send the blood to the tissue compartment. And the tissue compartment is going to receive the air that is dissolved in the blood. And it's going to perform metabolism. It's going to perform metabolism. And metabolism, in order for us to get ATP, that's a good thing, that's a positive thing. We get ATP, but obviously we don't get only ATP, we get also some negative, toxic metabolic waste that needs to be removed. Metabolic waste. There's going to be a lot of waste that needs to be removed, and then this waste is going to return back into the lung. Then the lung is going to expel it back into the air. So you see another circulation. So when we say circulatory system, we only remember the blood flowing inside the blood vessels and the heart. But what you realize in addition is that there is another circulation, and that is the respiratory system circulation. You see, that's a circulation. We bring air into the lungs send the oxygen. The lungs send oxygen into the blood circulation. The blood circulation is going to deliver the oxygen to the tissue for metabolism. Why do we need oxygen? We need oxygen for aerobic respiration. We need oxygen for aerobic respiration. We need oxygen for aerobic respiration because aerobic respiration or oxidative phosphorylation, oxidative meaning using oxygen, phosphorylation meaning we make ATP. ATP is made up of phosphates. Phosphorylation. The aerobic respiration and the oxidative phosphorylation are both going to be taking place in the mitochondria. The mitochondria. And this mitochondria is going to generate ATP. Why do we need ATP? Why are we going through all of this? Oxygen, oxidative phosphorylation, the mitochondria, ATP. Why do we need all of that? Why do we need ATP? Why are we going through all of this hassle? Bringing in air, oxygen, aerobic respiration, oxidative phosphorylation in the mitochondria. Then the mitochondria is the powerhouse of the cell that gives us ATP. Why do we need ATPs? Yeah. Yeah, in order to power the enzymes. And the enzymes do not work without ATP. And why do the enzymes need ATP? In order to power the biochemical reactions that sustain life. To power and sustain life. So this metabolism requires enzymes. When we do the metabolism chapter, we will see that. The metabolism requires enzymes. Survival requires enzymes, and so on and so forth. So we have given our tissue oxygen, then the tissue uptake the oxygen, and the tissue uptake the oxygen and cause metabolism, and we powered our enzymes with ATP. Then we generate waste. What's the waste that we are going to generate as a result of performing our metabolism? This is going to be carbon dioxide and other forms of metabolic waste like nitrogenous waste, And all of that is going to return back to the lungs again. And the lungs is now going to send out the carbon dioxide out into the atmosphere. So that's another circulation. But in the end, the circulation, no matter what, still depended on a pressure gradient. So if you look here in step A, where oxygen is flowing from the air into the lungs, well, that's a movement. And we said fluids do not move except from an area of a high pressure to an area of a low pressure. So that shows you there is a high partial pressure for oxygen in the atmosphere, and there is a low partial pressure minus low partial pressure of oxygen in the lung. And if oxygen is going to go from the lung to the blood, then you bet that the blood circulation has even lower partial pressure for oxygen than the lungs. And if the oxygen is going to go into the tissue compartment, then you know that the tissue compartment has even lower partial pressure for oxygen than the blood circulation. And then if the blood has been used completely and now we need to now shunt and remove. We need to now shunt and remove carbon dioxide, because you don't want a lot of carbon dioxide building up in the tissue. That's gonna poison and that's gonna kill the tissue. So in order for carbon dioxide to flow out from the tissue compartment, into the lungs, that requires that there is a high partial pressure of carbon dioxide in the tissue compartment compared to the lung having a low partial pressure compared to the tissue compartment, and the air is going to have the least partial pressure for carbon dioxide, the least partial pressure of carbon dioxide compared to the lungs. Is that concept clear? So we're never going to move whether we are gas fluid or liquid fluid except from an area of a high pressure to an area of a low pressure. So now we established already that gases are not moving except from an area of a high pressure to a low pressure. So now we get back to the original question. How do we manage to create a high pressure environment in which we have the oxygen flowing into the tissue compartment? For example, let's now look at your rib cage. This rib cage is made up of, it's a cage. It's made up of a lot of bones. These bones, are they fixed in place or do they move? These bones, they move. When you take a deep breath, what happens to them? They expand outward. So what happens to the transverse diameter of the rib cage? What happens to this diameter? So let's say now I'm looking, this is the diameter of my rib cage. If I am inhaling air, is the diameter going to expand outward or is it going to compress inward if I am trying to inhale? So if I'm trying to inhale, this is my rib cage. Let this circle represent the diameter of your rib cage. The transverse diameter, this is the transverse diameter of your rib cage. If you're trying to inhale if you're trying to inhale air, what do you think is going to happen to the transverse diameter of your rib cage? It's obviously going to expand outward. So there is a lot of stretching on the outside in order to increase the volume. So when we're inhaling, the rib cage expanded outward in order to allow us to bring in the air inside of the rib cage. What if I want to exhale now? What if I want to exhale? If I want to exhale, then what I'm going to do is I'm going to do the opposite. I'm going to bring the rib cage inward. I'm going to bring the rib cage inward, and my volume, so when I'm inhaling, my delta V, the volume is going to be very high. The volume is going to be very high when I'm trying to inhale. I'm going to expand the transverse diameter of my rib cage. But if I'm exhaling, what's going to happen to my delta V if I'm exhaling? What is going to happen to delta V when I'm exhaling? Exhaling, not inhaling. Yeah. Yeah, it's going to get smaller. Very good. It's going to contract. But when I am inhaling, it's going to get bigger. So what's the relationship now? What's the relationship between volume and pressure? Because remember, if it wasn't for pressure, air is never going to move. But since our volume is being modulated, one time the volume of the rib cage is high, one time the volume is low, so there's got to be a relationship between the volume and the pressure. So what's the relationship between the volume and the pressure? The relationship is the following. Remember from chemistry, PV equals nRT. The law is known as Boyle's law. What does Boyle's law say? Boyle's law says that if you have a constant temperature, many students say Boyle's law says that the pressure and the volume are the opposite. That is not true, because they forgot the most important piece of the law, and that is only if the temperature is constant, like physiological homeostatic temperature. In physiological and homeostatic temperature, when my temperature is constant, now I can apply Boyle's law. Why is my temperature constant? Because I have homeostasis. When it's cold outside, I shiver in order to maintain a constant internal homeostatic environment. When it's hot outside, I sweat in order to maintain a constant homeostatic internal temperature. So your body is excellent at maintaining a constant temperature. Now, if the temperature is constant, then the relationship between the pressure and the volume will always be opposite or inverse. Very good. So now let's look at that. If I'm trying to breathe in air, so now we're at A, point A. See point A? I'm trying to bring in air into my lungs. If I'm trying to bring in air into my lungs, I want air to flow from the atmosphere into the lungs. So that means who must have a high pressure and who must have a low pressure if air wants to come from the atmosphere into my lungs?
Atmosphere should have the high pressure.
And the lungs should have the low pressure. That's during inhalation. Very good. So during inhalation, the atmospheric pressure is going to be very high compared to the lung pressure. It's going to be very low, and the air is going to move inward. But how did we change the pressure in the air? Did we go out in the atmosphere and change the pressure in the air? We did not. but we changed the volume of our own rib cage. We expanded the transverse diameter of the rib cage has been expanded, and we know the relationship in Boyle's law is if you expand the volume, what happens to the pressure at a constant temperature?
Remains the same.
No, it does not remain the same. When temperature is constant and you increase the volume, what happens to the pressure?
It increases.
No, it does not increase. We said when the temperature is constant, the relationship between the pressure and volume is always going to be opposite, inverse. So when I'm taking a deep breath, my temperature is not changing because I'm at homeostasis, 37 degrees Celsius. And I took a deep breath, so the transverse diameter was stretched out, so my volume has increased. What's going to happen to the pressure now?
Decrease.
It's going to decrease. And when the pressure decreased in my lungs, because my rib cage moved out, the pressure decreased, then the air is going to flow in so smoothly and nicely. Now you see how you end up breathing? It's because the rib cage moved out, made high volume, pressure dropped, air went in. What about the opposite? If you want to exhale now, if you want to get air out, we're now here at this step. This is exhalation. So now we want to get the air out, not in. So who should have a high pressure? If I want to get the air out of my lung, I have my lung pressure. We call it the pleural pressure, intrapleural pressure, PIP. The pressure of the lung is the intrapleural pressure, intrapleural pressure. That's the lung. And outside is not going to change. That's the atmospheric pressure. Outside is always the atmospheric pressure. If I want air to go from my lung to the air, who should have a high pressure and who should have a low pressure?
Lungs should have high pressure.
Excellent. So the lungs should have a high partial pressure for carbon dioxide. And the air should have a very low partial pressure for carbon dioxide for the air can go smoothly. How do we increase the intrapleural pressure? How do we manage to do that?
By decreasing the volume.
Excellent. By when you exhale, your transverse diameter is gonna compress your lung, squeeze against your lung, and when you compress the lungs, when the rib cage compresses the lungs, what happens? The temperature is never going to change. It's 37 degrees Celsius. But when you're exhaling, the volume is going to drop severely and the pressure is going to increase dramatically, like that. And then what happens now? The air has moved out. So now you see that your rib cage, when you did the bone, the skeletal system, back in A&P1, you learned that the bones are not only important for walking and movement, they are important for breathing. If you fracture one of the ribs, you will have a problem with maintaining the proper pressure for air to go inside your lung. Now, there's one thing that's very important. This volume, the volume of your respiratory system, is it only controlled by, is the volume in your respiratory system only controlled by your rib cage? Who else is also participating in the volume of your rib cage? Is it only the bones, the rib cage, the bones and the muscles only, or there's something else? What else is participating in the size? Yeah, the diaphragm. Very good. So what is the diaphragm? The diaphragm is a muscular sheet. The diaphragm is a muscular sheet, a sheet of muscle. What does the diaphragm do? The diaphragm, this is very important. Now, if you look at the chamber, you will see that the diaphragm has the following. This is your lung. This is your lung. And the diaphragm, you know, over here you have your rib cage. We talked about that. We talked about the rib cage around. Rib cage is on top, north, west, east. North, west, east. But on the bottom, the south, you have your muscular sheet, the diaphragm. The diaphragm is here. How does the diaphragm work? This is your diaphragm. This is the diaphragm. This is very important. The diaphragm is elastic. Elastic. The diaphragm is elastic. Elastic. The diaphragm is malleable. Meaning that it's like a rubber band. It can stretch. So when you want to take a deep breath, how does the diaphragm work? Let's look at the diaphragm during inhalation. Let's look at the diaphragm during the inhalation. The diaphragm during inhalation, does it move up or down? So you know in inhalation, do you want to make the volume high or do you want to make the volume low? You want to make the volume high so that the pressure can drop. So do you think that the diaphragm is going to stay at this level, or is the diaphragm going to move down? What do you think is the diaphragm going to do during inhalation?
Contract and flat.
It's going to contract. It's not going to flatten. During inhalation, if it flattens, the chamber is not going to be big. But if it moves down, now look at all this room now. So it's going to contract by moving downward. So the diaphragm is going to contract by moving down. The diaphragm is going to contract by moving down, and that is going to increase the volume of your respiratory cavity. And when you increase the volume of the intrapleural pressure is so high, the volume of the intrapleural cavity is so high, that means the pressure of the intrapleural pressure is going to be so low, air is going to move in inhalation. In exhalation, what's going to happen to the diaphragm? Is it going to move down? Remember, the movement of the diaphragm down, do we call that, this is very, very important, do we call that relaxation or do we call that contraction? That's contraction. The movement of the diaphragm down is known as contraction. Now, if you bring up the diaphragm, to the up near the lungs, remember we said it's malleable, elastic. So when the diaphragm moves up, it's called an elastic recoil. What's going to happen to the transverse diameter of your rib cage? What's going to happen to the intrapleural cavity volume? Is it going to increase or decrease? It's going to decrease because the diaphragm relaxed. So the diaphragm is like a rubber band. It stretches downward when you're inhaling. If you want to bring in air inside, it stretches downward, increases the volume of your intrapleural cavity. But when you want to exhale, it recoils right back up to squeeze the air out. Clear? Questions? Okay. Now, we have established the relationship between the pressure and fluid movement. We established the relationship between Boyle's law and breathing, where we do not pump air with like a vacuum pump, but we actually pump air with modulating the volume pressure relationship. If I want to inhale, I expand the volume by moving out my rib cage and moving down, contracting my diaphragm. Air comes in. And when I want to exhale, I relax my diaphragm and I also contract my rib cage. Air is going to flow out. The question is, if you look at the rib cage, this very interesting rib cage here, does the bone move by itself? Does the bone squeeze on the lung to decrease does the bone move by itself, squeeze on itself? What makes the bone move? What makes the bone stretch out? If you want to inhale, bring air in, increase the transverse diameter of the rib cage. What makes the volume decrease by contracting downward? What makes the bones do that? It's the muscles. So there are muscles that are sandwiched in the middle. Muscles that are sandwiched in the middle between your rib cage. These are the ones who make the rib cage expand outward during inhalation to increase the volume or contract inward during exhalation. Now, what do we call these muscles? There we go. There they are. There they are. You see these muscles here that are in between. These muscles that are sandwiched in between the rib cage, they are the ones who tell rib cage, it's time to inhale. Move, stretch out. So air goes in. It's time to exhale. Contract inwardly and air comes out. These muscles are known as the intercostal muscles. These muscles are known as the intercostal muscles. These intercostal muscles, Phil. You see, they are the ones who stretch out the rib cage. You see, they are right in the middle. So, who makes these muscles contract in order to expand the transverse diameter of the rib cage? Who makes these muscles change the volume, the intrapleural volume of your respiratory system? It's the brain. So your brain is constantly monitoring. So the brain is constantly monitoring, first of all, your blood. There are chemoreceptors. There are chemoreceptors. There are chemoreceptors. What do the chemoreceptors do? The chemoreceptors, they taste the blood. Like they taste the soup. They taste the blood and they see that the blood has a lot of carbon dioxide. That means the blood is acidic or basic. If the blood has a lot of carbon dioxide, does that make the blood acidic or basic? Makes it acidic. So now the brain is going to tell the rib cage, hey, hyperventilate, shunt off, remove this carbon dioxide, get this carbon dioxide from the blood out into the atmosphere, hyperventilate. So now your brain is going to be sending a lot of action potential, and the action potentials are going to stimulate your intercostal muscles to contract and relax, contract, depolarize, contract, repolarize, relax at a faster pace in order to accommodate for the removal, this emergency, urgent removal of this carbon dioxide from the blood compartment into the atmosphere. But if you are sitting down on a Saturday afternoon, you're not running, you're just relaxed, you're watching TV, and the brain with the chemoreceptors is not tasting a lot of carbon dioxide, your blood is not acidic. So it's the rate now of the breathing is not going to be as rapid. So you have to understand that these intercostal muscles, if you look here, how many different types of intercostal muscles do we have? We have internal intercostal muscles and external intercostal muscles. Is that clear? Internal intercostal muscles and external intercostal muscles. Please take a 10-minute bathroom break and no going out after the break. Please take a 10-minute bathroom break and we're gonna start the slides. Okay? 10 minutes exactly. 10 minutes. Not 11, not 10 and a half.
Not playing games with us. What about the day?
She advised that cancel your appointment with less than 3 business days. Don't disturb yourself in a missed appointment charge.
Be like, no. Just explain to him how you accept confirmed it by accident just today. And they just sent you the request to make the appointment. It's not like they made it a couple of minutes ago. I'm pretty sure they'll override it.
Surgery that I have scheduled for tomorrow at 9:30. Yes. Is there any actually? Can I reschedule now?
Are you just gonna edit it out? You know how to edit?
What about this one?
Yes, I'm just gonna leave it in there.
Huh?
I'm just gonna leave it in there.
You're gonna leave it in there? Don't leave it in there. That's unprofessional.
You can fast forward.
Okay, thank you so much for having me. Scheduled for January 5th.
Okay, please go to next. No problem.
Alright. And then January 5th?
Go to next.
What is it, a week there?
Monday.
And then you just ask for a week off and that should be enough. If you get to work. How do you buy the weekend? You go back to work on the weekend?
Well, I would just have a call out on Monday, and then I would be able to.
Well, how about you let them know now, not to schedule on Monday? That way you won't have to call out.
It's not gonna be busy.
I literally saw that. So I was
I was
laughing.
like, what is going on?
I guess it's like an illusion. No way. Look what they put in the comments. You know who I thought about? What? Mega Man? No.
Okay, everybody, please go to D2L week October the 22nd and download the PowerPoints for the respiratory system. Okay, so let's continue our discussion with the respiratory system. And we're going to see that the respiratory system is divided anatomically and physiologically into two regions. Okay, so let's go back to our initial discussion. The same way we target all types of systems from an anatomical and physiological standpoint, the respiratory system will not be any different. So let's now look at the respiratory system from an anatomy and physiology standpoint. Okay. The respiratory system. We're going to look at the respiratory system from an anatomy, also known as structure, and physiology, also known as function. Okay, so what is the respiratory system anatomically speaking? The respiratory system anatomically is divided into two separate systems. Remember how when we talked about the digestive system, we said there's an endoscopy. So there's an upper digestive tract and a lower digestive tract. Today we're going to find that there is an upper upper respiratory tract, and there's also a lower respiratory tract. Now, these upper respiratory tracts extend from your nasal cavity. So your respiratory tract entirely begins with the nasal cavity, then the oral cavity, then you have the nasopharynx, then the oropharynx, then the laryngopharynx, then the trachea, then we have now entered the lungs into the primary, secondary, tertiary, primary, secondary, tertiary bronchioles, and lastly you end up with the alveoli. So from your nasal cavity all the way until the larynx, all of these structures: nasal cavity 1, oral cavity 2, nasopharynx 3, 4, oropharynx 5, laryngopharynx, and then the larynx 6. Forgot about 6. The larynx. Number 6, the larynx. All of that, what does that represent? That represents your upper respiratory tract. That is your upper respiratory tract. From the trachea and down, from the trachea and downward, the trachea 7, primary bronchioles 8, secondary bronchioles 9, tertiary bronchioles 10, alveoli 11. This is the lower respiratory tract. Upper respiratory tract and lower respiratory tract. This is anatomically, structurally speaking. So you see the upper respiratory tract is nasal and oral cavities, in addition to the larynx and the different types of the oropharynx, nasopharynx, laryngopharynx, and your lower respiratory tract is everything from the trachea and downward. The trachea, the bronchioles, and the alveoli. Is that clear? Are we clear with the anatomical landmarks of your upper respiratory tract and your lower respiratory tract? Are we clear? Okay. That is anatomically speaking. What about structurally? That is structurally and anatomically. What about physiologically? Physiologically, your respiratory tract is divided into two systems. It's divided into a conductive respiratory tract and conductive respiratory tract and a respiratory zone. So there's two zones: conductive zone and a respiratory zone. So how is that different? How is the physiology of the respiratory system different from the anatomy of the respiratory system? How are they different? The first thing you need to understand is that, you know, when they say an upper respiratory tract infection and a lower respiratory tract infection, the upper respiratory tract infection only contains those regions, while the lower respiratory tract infection contains all the regions that are below. But when it comes to functionally, what are the functional responsibilities of your respiratory tract? What are the functional responsibilities of the respiratory tract? Number one, conducting the air. So everything in your respiratory system is conducting the air to the alveoli. The alveoli is that's the queen of the respiratory system. Everybody is trying to pass the air to the queen, to the alveoli. So the nasal cavity, conductive system. Oral cavity, conductive system. Nasopharynx, conductive system. Oropharynx, conducting the air. Laryngopharynx, conducting system. Laryngopharynx, also conducting. Trachea, conducting system. Primary, secondary, tertiary bronchioles, conductive system. Then once the air has arrived to the alveoli, then you begin your respiratory zone. So everything is part of the conductive zone, except the alveoli. That's your only respiratory zone. So the respiratory zone is only the alveoli. Alveoli are your only respiratory zone. But the conductive zone is everything else except the alveoli. That's why patients who get a lung transplant, it's because something is wrong with their alveoli. Something is wrong with the queen. Something is wrong with the respiratory zone. If anything is wrong with the nasal cavity, that could be repaired. Anything is wrong with the oral cavity, it could be repaired. Something is wrong with the trachea, we can repair that. Something is wrong with the bronchioles, can be repaired. But if something is wrong with the alveoli, it can never be repaired, and you need a new lung. So the alveoli are the most important part of your respiratory system. So when we look at the respiratory system, it's an organ system. It's a combination of cooperating organs that take in the air rich in oxygen, delivering it successfully to the blood, conducting the air from the atmosphere, delivering it to the tissue, and then shunting, removing, detoxifying the tissue from the carbon dioxide waste and sending it back into the air. So it is the organ system that takes in air and expels it from the body. Respiration refers to ventilation of the lungs, and the functions of the respiratory system are gas exchange, where you have oxygen and carbon dioxide exchange between the blood and the air, and there's a communication. In the communication, there's so your respiratory system is important for your communication. That's why when you have a bunched up stuffy nose, you talk like that, and it affects the way you speak. So your respiratory system is not only for breathing, it's also important for your speech. And remember, the respiratory system has two jobs. The first job is to conduct and pass the air from the outside during inhalation and to conduct it outward. And the second job of your respiratory system is to transfer the air into the blood, and then the blood is going to take it from there and deposit it into the tissue. Acid-base balance, we discussed that. We said that there are chemoreceptors that are constantly tasting the blood. Is it rich in carbon dioxide? That means that's dangerous. There's too much carbon dioxide. We need to get rid of that carbon dioxide. So that's going to increase the rate of hyperventilation. What's your nervous tissue response? What is the response of your respiratory system when there is too much carbon dioxide in your body? Like when you're exercising.
Hyperventilate.
Yeah, you're going to hyperventilate because you want to shunt and remove the carbon dioxide out. Blood pressure regulation. You have to understand that the lungs are important for secreting a hormone known as angiotensin II. Angiotensin II is important because it increases blood pressure. That's why there's a whole class of medications. When you take pharmacology, you will learn them. These are known as ACE inhibitors. ACE inhibitors. What are ACE inhibitors? ACE inhibitors, ACE, A-C-E. ACE means, it's an enzyme. Angiotensin converting enzyme. Where do you find ACE? Angiotensin converting enzyme, you find it in the lungs. Angiotensin converting enzyme is found in the lungs. So you see that your respiratory system is tightly knit and close to your circulatory system. That's why we say the cardiopulmonary system. Cardiopulmonary. The same way when we have the muscle and the bone, we say musculoskeletal. We combine together musculoskeletal. We combine together cardiopulmonary, and we combine together genitourinary. Genitalia with urinary system, and the lung, pulmonary, and the circulatory system, and you have your musculo and skeletal system. The respiratory system is also important for creating a pressure gradient between the thorax and the abdomen, and that actually helps propel and push forward the lymph fluid and the blood. The respiratory system is responsible for platelet production. So more than half of the platelets are made by the megakaryocytes in the lung. So the megakaryocytes, what are the platelets? What are platelets? Platelets are fragments. Platelets are fragments of the tissue known as the megakaryocytes. And we make most of the megakaryocytes in the lung. Blood filtration. The lung filters small clots and removes them from the body to prevent hypercoagulability and increasing the viscosity of the blood, to preventative measure against the formation of blood clots. Also, the respiratory system is important for the expulsion of the abdominal content. So the breath holding is going to assist in the urination, in the defecation, and during childbirth as well. Okay, the organization of the respiratory organs. We discussed that. We have a conducting zone and we have a respiratory zone. The conducting zone is just conducting and passing the air where? To the alveoli. Very good. And the respiratory zone is a region that participates in gas exchange between the lung and the blood. In the lung and the blood. Anatomically, the airway from the nose through the larynx is called what? The upper respiratory tract. And the lower respiratory tract represents regions from the trachea to the lungs. So if you look at the respiratory system, we have a nasal cavity in the hard palate, and there is a posterior nasal aperture There's also a soft palate and the epiglottis. So if you see here, your respiratory tract is divided into upper respiratory tract that begins with the nasal cavity and the oral cavity. And you see the pharynx, the trachea. And once you get to the larynx, that's the last part of the upper respiratory tract. If you look at the anatomy of the nasal region, that's the root of the nose. This is the nasal bridge. This is the apex of the nose. And this is the nasal septum. And if you see that all of this is cartilage. So cartilage is modified. The people always go and they do the surgery to repair the cartilage of the nose. How does it look like? People do that now. Yeah.
It's called a rhinoplasty.
Rhinoplasty. You did the rhinoplasty?
No.
You said you wanted to do one?
Yeah.
I should do one too. Have my nose look like this. Okay. So, the structure of the nose. The lamina propria contains large blood vessels to help warm the air. This air that is coming inside your nose is full of bacteria. This air is not sterile, but your bodily tissues are sterile, except your GIT and your respiratory system. Those ones have endemic bacteria, but your blood is pure. No bacteria on it, thanks to the white blood cells. So when the air comes in through your nose, it has to go, you see these nasal hair inside your nose? It's gonna be like a mop, like the bathroom mop, mopping out, filtering, trapping all of the bacteria and the debris and the sand and the dust that enters into your nasal cavity. In addition, the oral and the nasal cavity, since air is coming through them, they are laden and full of viscous mucus plug. Like, you know, the mouse trap has glue on it. Your nasal cavity is rich in mucus glue to trap. To trap what? To trap the mouse? To trap the bacteria. To trap all the microbes that are going to try to enter through your nasal cavity and your oral cavity. Okay, so if you look at the upper respiratory tract, you see that we have the nasal conchae. These are important for focusing the air and channeling it, funneling the air from the nasal cavity into the rest of the conductive part of the respiratory tract. Then you see that there is a lot of cartilage. That's what gives your nasal cavity its tensile strength. And you see the air is going to go through the nasopharynx, the oropharynx, and the laryngopharynx. The pharynx is a muscular funnel extending about 13 centimeters from the posterior nasal aperture to the larynx. It is divided into 3 regions. There's the nasopharynx, the oropharynx, and the laryngopharynx. So the pharynx is a muscular funnel extending from the posterior nasal apertures to the larynx. So divided into 3 regions: the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx passes only air and is lined with pseudostratified columnar epithelium, and that is rich in goblet cells which secrete the mucus. Muscles of the pharynx assist in swallowing and speech. Cartilaginous chamber, about 4 centimeters long, that is your larynx. The primary function is to keep the food and a drink out of the airway. It is also involved in the production of sound. It is so commonly called the voice box. It's called the voice box. Remember, the larynx is your voice box. Okay, if you do an endoscopy of the respiratory tract, you see that this is the epiglottis, and that's the trachea. These are the vocal cords. And you see that the actions of some of the intrinsic laryngeal muscles, you see that there's a lot of smooth muscle in your upper respiratory tract, particularly in the trachea. Why do people always have asthma? Asthma is not because something is wrong with the trachea, but it's because the smooth muscle tissue that is lining the trachea is going to be inflamed because of an overt immune response that is triggered by an allergen, causes this smooth muscle to contract. The trachea, the windpipe. You know, in anatomy and physiology, we have nicknames for structures. We call the patella the kneecap. We call the scapula the shoulder blade. We call the clavicle the collarbone. We call the calvarium the skull cap. We call the trachea the windpipe, because air goes in it like a pipe. Alrighty, so this is the trachea, and the trachea is going to have a point where we separate into both lungs. So the trachea begins as a one windpipe, then it divides into two windpipes. That's the bifurcation. There's a lobar bronchi, segmental bronchi, that's the main bronchi. The tracheal epithelium showing ciliated cells and non-ciliated goblet cell. The tracheotomy is to make a temporary opening in the trachea and insert a tube to allow for the air to flow. The tracheotomy is to make a temporary opening in the trachea and insert a tube to allow the airflow. So it prevents asphyxiation due to the upper airway obstruction, and potential problems include inhaled air that bypasses the nasal cavity and is not humidified. If left for long, it will dry out the mucous membrane and it's going to become encrusted and interfere with the clearance of the mucus from the tract. The intubation is when a patient is on a ventilator and the air is introduced directly into the trachea. So the air must be filtered and humidified. That shows you if you have a tracheostomy. The tracheostomy is going to try to replace your upper respiratory tract. So your upper respiratory tract had hairs to trap any dust. The upper respiratory tract had glue to trap any bacteria that comes in. It had turbinates and spaces that would humidify and heat up this air, because you don't want too cold air to go inside your respiratory tract. Well, now that is not possible. So the machine now is going to try this intubation tube. The intubation machine is going to try to repair this problem. So if you look at your lung, always the structure is going to give us the function. Structure is going to give us the function. So the larynx is the thyroid cartilage. There's a thyroid cartilage, there's cricoid cartilage, there is trachea. And in the apex of the lung, this is the apex is the top part of the lung. as the apex of the lung. This is the costal surface. That's an oblique fissure. This is the oblique fissure, and that's the horizontal fissure. What do you notice? It is your right lung that has 3 lobes. Your right lung has an apex, and it has 3 lobes because how many fissures are found in the lung? How many fissures are found in the lung? There's a horizontal fissure, and there is an oblique fissure. Horizontal fissure and oblique fissure. 2, dividing your right lung into 3 lobes. But on the left lung, how many lobes do you have? Only 2, because there's only 1 fissure. What is it? The oblique fissure. It's interesting, both lungs have an oblique fissure. Both lungs have an oblique fissure. The right lung has an oblique fissure, right here, oblique fissure. The left lung, oblique fissure. It is only the right lung that has a horizontal fissure. Are we clear? Are we clear? That's the apex. That's the superior lobe. So the pulmonary arteries. And if you see here, there's a cross section through the thoracic cavity. The left and right lungs are not symmetrical. And if you look at the right lung, it is shorter than the left because the liver rises higher on the right. It has 3 lobes: superior, middle, and inferior lobes, because it possesses 2 fissures: horizontal fissure and oblique fissure. The left lung has 2 lobes, a superior and inferior lobe, and they are separated by a single oblique fissure. The bronchioles. The bronchioles are continuations of the airways that lack supportive cartilage and are 1 millimeter or less in diameter. The pulmonary lobule, that's a portion of the lung that is ventilated by 1 bronchiole. They have ciliated cuboidal epithelium and well-developed layer of smooth muscle. Cells of the alveoli. So the alveolar macrophages, known as the dust cells. So these are the resident sentinel white blood cells that are like police. They are on the airways because with the entry of the air, a lot of infectious pathogenic microbes are going to try to infiltrate. So you need your alveolar macrophages or dust cells to be resident in your alveoli to ensure that this bacteria doesn't leak into the blood, because the alveoli is exchanging air with who? The alveoli is exchanging air with the blood. So if this air is not sterile and clean from the macrophages, then that's going to lead to sepsis and blood poisoning with this infectious pathogenic microbes. There we go. Those little bubbles represent for us the alveoli. There are great alveolar cells, and there are alveolar macrophages. And these alveolar macrophages, they are patrolling immunosurveillance to ensure that we don't have any infiltrate of macrophages. Now if you look at the lungs and the bronchial tree, so the respiratory membrane represents a thin barrier between the alveoli air and the blood, and each alveolus is surrounded by a basket of capillaries supplied by the pulmonary artery. The gas is exchanged across the respiratory membrane, which consists of 3 layers: the squamous alveolar layer, endothelial cells of the blood capillary, their shared basement membrane. What's the pleura? The pleura is a serous membrane that lines the thoracic wall and forms the surface of the lung. So here you have the visceral pleura. It forms a surface of the lung, and parietal pleura adheres to the mediastinum, the inner surface of the rib cage, and the superior surface of the diaphragm. The pleural cavity is a potential space between the pleura, and normally there's no room between the membranes, but contains a film of the slippery pleural fluid. So the pleural effusion is, remember when you guys did AMP1, you guys learned that all of the viscera, whether your lung, whether your heart, whether your brain, they're always enclosed in a cushion, in a balloon that is protecting this viscera from any trauma or damage. That balloon is not an empty balloon. It's not a balloon full of air. It's a balloon full of serous liquid fluid. So does the lung. The lung is a viscera, soft tissue. So the lung is encapsulated, enclosed with a supportive cushion that is like 2 layers, a balloon that is full of serous liquid. When that serous fluid gets infected with bacteria, what do we call that? Pleural effusion. Pleural effusion. Now, when we look at the normal quiet expiration, normal quiet expiration is when we're looking at an energy-saving passive process achieved by the elasticity of the lungs and the thoracic cage. So as the muscles relax, the structures are going to recoil to the original shape and the original smaller size of the thoracic cavity. They result in the airflow out of the lungs. What's the Valsalva maneuver? The Valsalva maneuver is a breathing technique which helps you to expel contents of some certain abdominal regions. So we discussed this earlier. The inspiratory muscles and the expiratory muscles. These are your intercostals. The internal intercostals and external intercostals. What's the difference between the internal intercostal and the external intercostal? What's the difference between internal intercostals and external intercostals? So internal intercostals are towards the center of your rib cage, while the external intercostals are far to the sides. So if you look here, which ones are your internal intercostal muscles? The ones who are closer to your sternum, those are the internal intercostals. External intercostals are the ones that are far away. Neural control of breathing. It's the breathing that depends on the repetitive stimulation of skeletal muscles from the brain So the breathing depends on the repetitive stimulation of the skeletal muscles from the brain and will cease if the spinal cord is severed high in the neck. So the skeletal muscles require nervous stimulation. The multiple respiratory muscles require coordination. So breathing is controlled at 2 levels of the brain, and one is cerebral and conscious, and the other is unconscious and automatic. So the respiratory control centers in the central nervous system. So remember what we discussed earlier, that your brain has chemoreceptors. And these chemoreceptors, they are tasting the blood to see if there's carbon dioxide. So you see that this is the internal intercostal muscles, and this is the intercostal nerve. You see what we said earlier. The muscles are the ones that pull your rib cage out to increase the transverse thoracic diameter of the rib cage. But it is the nerve who's responsible for stimulating. The nerve is the one responsible for stimulating the muscle and increasing the transverse diameter. What are the two nerves who are responsible for the output signal? So obviously, the input sensory signal to the respiratory centers of the medulla are bringing in sensation that there is an increase in the carbon dioxide. We need to breathe faster. The red or purple here are the output signals. These are going to the spinal centers and the respiratory muscles, and they are going to cause the actual motor effector output. So the muscles are effectors. They are somatic effectors that receive a motor output that is coming from the brain. But the brain is never going to send a motor output to the muscles unless it has a sensory stimulation that the carbon dioxide level is going up, and we need to increase the level of the hyperventilation. So these are the receptors we talked about earlier. The central chemoreceptors and peripheral chemoreceptors. So in order to understand the central chemoreceptors and the peripheral chemoreceptors, the central chemoreceptors are found in the, why do they call them the central chemoreceptor and the peripheral chemoreceptors? Central chemoreceptors, it is because they are in the central nervous system. They are found in the brain stem. Where do we find the brain stem? In the brain, in the central nervous system. And they respond to changes in the pH of the cerebrospinal fluid. The pH of the cerebrospinal fluid is going to reflect the carbon dioxide level in the blood. And it's going to regulate the respiration in order to maintain a stable pH, and it's going to ensure that there's a stable carbon dioxide level in the blood. Peripheral chemoreceptors. Those peripheral chemoreceptors, those are carotid and aortic bodies, and they respond to oxygen and carbon dioxide content and to the pH of the blood.